Welcome to Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware with Dr. Nicholas Biasotto. Dr. Biasotto is board certified in family medicine, and he has extensive experience and training in treating patients with addiction and substance abuse. Now, let's join Dr. Nick Biasotto for Delaware Healthcare Reality.
Hello everyone, this is Dr. Nick Biasotto, a host of the Medical Society of Delaware's podcast, Delaware Healthcare Reality. I'm happy to say this is our 35th podcast. We have a very special guest on today, Dr. Andrea Klemes, and I'm going to introduce her formally in a bit, but I would like to give a brief introduction. The topic of our conversation today is concierge medical practices. What is a concierge medical practice? It's a different model for medical practices. The model allows for the decrease in the number of patients that any one doctor has in his or her practice. By lowering the number of patients in a doctor's panel, it allows for more time spent with the doctor, and timely appointments can be made. If a patient is sick, they're usually seen the day they are sick or no later than the day after. It also lowers the expense of maintaining a practice by lowering the need for a large employee base. It also allows for home visits for patients who are homebound. A patient also receives an extremely extensive physical, up to 2 hours, which incorporates the evaluation of every system in the patient's body, i.e. vision, hearing, respiratory, circulatory, cardiac, neurological, medical, and the skin. We also evaluate the skin for any abnormal lesions. A large panel of cutting-edge blood work is also included, allowing the doctor to set up a wellness plan to improve and maintain a patient's health. Needless to say, physician burnout is significantly reduced. With this medical model comes a yearly fee that a patient pays to stay in the doctor's panel. There's a lot more in this medical model, which we will explore with our guest today. Our guest is Dr. Andrea Klemes. Dr. Klemes is a board-certified in internal medicine and endocrinology. Andrea's principal role as Chief Medical Officer is leading and shaping MDVIP's physician-led primary care model. A fellow of the American College of Endocrinology, Dr. Klemes works closely with the 20 physicians on MDVIP's Medical Advisory Board and MDVIP's more than 1,000 affiliates nationwide, drawing from their expertise and knowledge to drive quality and innovation in the delivery of MDVIP healthcare model. She works to identify tools and tests to help those affiliates better identify risk and prevent disease. Using clinical and cost data from MDVIP's membership, Dr. Klemes has authored 9 studies showing patients in this model enjoyed better outcomes in areas like hospitalization, emergency department utilization, preventative services, and cost savings than patients in traditional primary care practices. Quote, as she has said, one of my driving factors has always been that, in addition to great doctors, we can show that MDVIP directly impacts patient health in saving lives and also in accumulating enough information to inform and encourage other physicians to join. She also says it is why we stay focused on furthering education for our physicians and rigorously piloting new tests and treatment programs to continually evolve the process through MDVIP. Before joining MDVIP, Dr. Klemes worked at Procter & Gamble in personal health care, women's health, and digestive wellness. She also served as a North American medical director for bone health. She spent 10 years in private practice, specializing in endocrinology and metabolism in Tallahassee, Florida, and has held leadership roles with the American Medical Association, Florida Medical Association, the Diabetes Center in Tallahassee and Panama City, Florida, and at Tallahassee Community Hospital, where she was the chief of the Department of Medicine. Andrea received her medical degree from the New York College of Osteopathic Medicine. She completed her internal medicine residency at Cabrini Medical Center in Manhattan and an endocrine and metabolism fellowship at the Medical Society of Georgia in Augusta. She has completed broad clinical research in diabetes and osteoporosis, has published extensively, and frequently lectured. Outside of her passion for medicine, Andrea plays golf and loves to spend time with her family. My first question is, what's your handicap?
Well, there's a story behind this. I don't have one, and I haven't played in about 2 years because my husband made a sharp right on the golf course like 2 weeks before Christmas one year, and I flew out of the golf course and hit my head on the cement.
Ooh.
Had a horrendous concussion, like woke up in the CAT scan machine.
Oh my God.
I said, oh my goodness, like where am I? Oh, I'm in a CAT scan machine. And then fell back out, woke up again, and so I haven't played as much golf lately.
Around here we haven't been able to. I usually have 30 or 40, games under my belt, but the weather has been so terrible, and it just hasn't been very good for conducive for going out and playing. Well, my handicap has, as my age increases, so does my handicap, and now my handicaps are, my shoulder hurts and my low back hurts, etc. Well, welcome.
I thought you were going to say MDVIP helped your handicap because you could actually get out on the golf course more.
Well, I can't. Well, I do have more time for it if the weather was cooperative. But welcome, Dr. Klemes. It's nice to have you here, and it's an honor and privilege to have you as our guest on Delaware Healthcare Reality. And as an MDVIP physician, I thank you and your organization's physician model for allowing me to continue practice at a professional level. I was going to retire 10 years ago, because I've been in your system now for about 10 years, when I was overwhelmed. I was seeing 30 or 40 people a day. I had a patient panel of 3,000. I could not give the time to the patient, and the pace that I was working under was just overwhelming. So, my first question to you, please tell us and our audience a little about Concierge medical model.
Sure. And I guess I'll speak more specifically to MDVIP since that's the one I know about. And, for those who don't know, MDVIP started 25 years ago, and it's a great story. There was a patient and a doctor, and the patient had made his money in the toy industry. And he went in to see his physician, and he was waiting in the waiting room for hours, finally gets back there and said to the doctor, oh my gosh, it's horrible out there. And the doctor looked at him and said, if you think it's bad out there, you should see what it's like back here. And that ended up being doctor number 1 in the network, and Rob Colton and doctor number 2, Bernie Kamenetsky, said there has to be a better way, found a couple friends. The number 1 patient ended up being the first investor in MDVIP. And they just knew that you needed to spend more time with patients to have that deep relationship like, many of doctors did back when we were kids, you and I. And so they tried to figure out, well, how can that be? Because we have insurance. And one of the things we've always been clear about is working with being able to be compatible with Medicare and commercial insurances. And as they were thinking through how could that work, they came up with the idea that, and validated it with CMS and others, that if you charge a patient for non-covered services, that's okay. I always use the example, a plastic surgeon can charge you cash for a facelift, right? Because Medicare is not covering that facelift. So when you look at what Medicare really covers for our patients, if you have no diagnoses for wellness and prevention screening, Medicare will cover a glucose once a year and a lipid panel once every 5 years. And that's it. And then that annual wellness visit, right, where you don't need a doctor or a stethoscope. So we knew that if you have time and you build a deeper relationship, and then we put together this executive style physical, that you can take better care of people. And so 25 years later from when we started, we have about 1,400 physicians across the country taking care of over 425,000 patients. And you mentioned the executive style physical that patients get. That's actually what the membership fee goes for when you think like legally. And then the perk of it is they get you for the rest of the year, and you to make that wellness plan, and you to talk to them and have the deeper relationship. So I get to publish all those wonderful outcomes and show our patients live longer. I've published that. Our patients have less heart attacks and strokes. I've published that. Better blood pressure, blood sugar control, more mammograms and flu shots, everything that it's just better medicine when you have the time to really spend with somebody.
Right. Was there any resistance initially when the concept came out and started to run?
There was resistance, and in fact, there was a young senator from Florida, Bill Nelson, who's now, not young anymore, and he had seen in an article in the paper down here that it said, I'm going to have to leave my doctor, was a patient. And it was over the fold, and under the fold it said, but I'm not going to. And it talked about how MDVIP was forming and that if you paid a membership fee, you got your doctor. And so, MDVIP early on had to go up to Capitol Hill and work with the senators and Congress people. And I've actually been up there with our team. We go proactively now. But the head of HHS at the time, Tommy Thompson, reviewed the model and said, it's all compatible with Medicare, it's all legal, and so, we think it's a good thing. And then the AMA in like 2002 or 3 reviewed MDVIP also. I was actually one of the delegates to the AMA from the Florida Medical Association at that meeting, and you never know what happens to you 20 or 30 years later, right?
Mm-hmm.
And the AMA said this sounds like an ethical, good way to practice medicine. HHS said this is fine and compatible. We've worked with insurance commissions over years. In Maryland, years ago, they went after a local physician who's not MDVIP, who they said was charging patients illegally and shouldn't do the model that they were doing. And we actually testified there, and when they made their legislation, they carved MDVIP out and said that MDVIP is a legal model, that doctors are charging for non-covered services. That's all fine, and we go by all our insurance contracts. So 25 years later, we don't get pushback anymore. We're in 46 states or 7 states in the District of Columbia. We're just not in those states with no people. Like, I think we're not in one of the Dakotas and Idaho and maybe Iowa. Maybe those are the 3 states we're not in. So, we work well with insurers. I've presented to CMS, and, it's one of the best kept secrets, I think.
I think you're absolutely right. And I didn't know anything about it until I was just about ready to retire, as I said earlier. And one of your members said, why don't you look into this, Nick? And I said, okay. So I don't know if you remember, but my wife and I came down to Boca and met with you and the CEO at the time. And when I left, I said, where do I sign? Because it just had everything. It had everything I thought was going to be very beneficial for me and my patients. And I've just been pleased since I've done this, and it allows me to keep going and doing something I really love. Okay, besides the few benefits I described earlier, what are the pros for joining a concierge practice through MDVIP, which is the largest one medical model out there? Anything I didn't mention you want to add?
Sure. So from the physician perspective, you're joining a large network of like-minded physicians. We have, national meeting, we educate, we have webinars. One of the cool things is that I get to do all the work and due diligence for new technologies, and I feel like you're all my baby birds, right? And I eat and spit it all back to you,
Okay.
So that we can educate you on new things that come out. And we have docs in the network who are so excited about that, as like Lou in Baltimore. And, a new study comes out that's, pivotal, and somebody will write something up and send it to you. Or, the new tests like Grail, or food sensitivity testing, or Prenuvo, the whole body MRI.
Correct.
I can do all the research with my team, and we can educate you. and then hopefully get, patients and doctors discounts on some of these things, because I have a little bit of clout with the big size that we are.
Well, they definitely do have some discounts offered to my patients for these cutting edge, in my opinion, processes that you guys have just put out there and told us all about. I fully enjoy Lou's almost monthly educationals. They're really good. And I think that our doctors who pay attention are well informed. Great. That's really good to hear. Anything else you was going to say there that I might interrupt?
Yeah, I guess some of the other things is, we have relationships with Mayo Clinic, Johns Hopkins, Cleveland Clinic, so that, Sloan Kettering, MD Anderson. So God forbid you have a patient who gets diagnosed with pancreatic cancer and you want them to see the best specialist in the country. We can get them into that best specialist, not the fellow or the resident. No offense to anybody training, but, our patients want the best of the best, and that's what we can help facilitate. My team will help make sure that the patient records actually get there, so that, and they work with you, so they would, work with you on a patient, you and the patient, and get them into whatever specialty, if you know what's wrong with them or not.
I have had that situation in my practice. I'll give you a specific example. 48-year-old guy and comes to me, and he had some difficulty swallowing. He was suggestive that there was something going on in his esophagus. I did a barium swallow, and it showed he had a tumor in his esophagus, and he went to our local, cancer center, I won't mention any names, and was told to get yourself in order, with him and his wife at that center, get yourself in order. I'm not sure we can help you. You may have a year to live. Well, they came from that place to my office that day. They're MDVIP with me, that day, and in tears. And I said, I'm not satisfied with that, because I've seen the pictures and all. I said, I'm not satisfied with that. I'm going to hook you up at Hopkins. 1 week later, he was at Johns Hopkins. He was given a year to live about 9 years ago. He's still functioning well. He had his procedures done at Johns Hopkins. They did a wonderful job. There's been no reoccurrence. And I think that link between my office and some of these tertiary centers like Hopkins is a great benefit for our patients. So,
it is. I think the only other one I'd add to you is reciprocity, so that, as a physician, knowing that if your patient gets sick in Boca Raton, you can call my doctor down here and get on the phone and say, hey, look, if it was me, she usually gets sinus infections. Sometimes it ends up in bronchitis.
Right.
Will you just listen to her lungs and see if she needs steroids?
Okay.
Or I think even more important is, this happened. Somebody called me and said, an affiliate called me. My dad's in the hospital in West Palm Beach. He has a bowel obstruction. Who can I call to find out if the hospital's good and the doctor is good? Gave him the name of the doc who was in that town. And the doc in the town said, great surgeon, great hospital, do not move him. But at least he had the peace of mind, and you
exactly.
can your person too. So it's helpful.
The
bigger network.
The connections with networking through MDVIP is just a tremendous benefit to our patients, for sure. And it takes a considerable burden off of us as we work along. I think right now we're going to take a brief break. We'll be back shortly. And we'll return in a bit.
Information about the Medical Society of Delaware can be found on our website, medicalsocietyofdelaware.org. Questions about our podcast can be emailed to healthcare.reality@medsocdel.org. That's medsocdel.org. Once again, here's Dr. Nick Biasotto.
Okay, we're back from our break talking with Andrea Klemes, who is the medical director of MDVIP Concierge Practices. Okay, we talked about the pros. Is there any cons to the practice of concierge medicine that you've heard or want to talk about?
Whenever we look at prospective physicians and we have affiliates who've been with us for a long time or a short period of time like you on a panel, and of course, that's what the docs who are interested in this always ask. What's the downside? What's the negative? The one thing every doctor says is, I should have done this sooner. You knew I was going to say that, didn't you? Because you started smiling.
I have said that numerous times.
So, I think that's it. There are practices that, it's not for everybody. That's why our team, who has analyzed thousands of practices, will be able to tell you if it's right for you. Do you have the right makeup of your practice? Do you have enough patients? Are you in the right kind of area? And we have so much data on that we can pretty much look at you and say, yes, this will work, and you should open up with X amount of patients. Mm-hmm. And we're usually pretty darn accurate.
Correct.
So, that's really the downside. For some people, we do work with physicians in every type of practice. So solo, groups, hospital employed, any type of practice configuration we have in our network. So we've done it before. And that way that, you still could be employed by a hospital system and
be a concierge practice. Cool. My biggest problem with it was leaving the many patients that I'd taken care of for so long. That was the only thing that was holding me up. But I had to do this for the benefit of the patients that wanted to stay. I had to do this for my benefit, giving me somewhat of a life and more time for myself and my family. I still get the patients who didn't sign up coming in saying, I miss you, Doc. I wish I could join. I always tell them, you got any questions? You want to bounce them off me? Call me anytime. And that's what seemingly has happened quite a bit in my practice. But that was the hardest thing for me to do. All right. I was going to ask that, and I think you sort of answered it already, but what is a good number of patients to limit your practice to? What is a good number?
We say that the cap is 600, and we figured out the 600 because when MDVIP started in 2001, there was an article in New England Journal, and it said if you want to focus on wellness and prevention, you need like 1 to 2 hours once a year and a couple of half-an-hour follow-ups. And then you throw in a sinus infection or your UTI, and you give the doctor a couple weeks of vacation, and 600 is about the max that you can have. Now, I know physicians who have in the 700s, and I know physicians who say 300 is my max. Mm-hmm. So I think it depends on your efficiency. When I was in private practice, I had a business partner. He was always an hour behind, and I was always on time. And you partners with those physicians over the years, one or the other. And so it's up to how the physician feels to say, I'm getting everything done in the day. I'm not, when doctors look to be in this model and they're like, well, I don't know. And to your point, I'm afraid, I don't want to leave my patients. Who else is going to take care of them? I'm like, have you ever come home at night or gotten to bed or gotten in the shower and then said, oh gosh, I forgot to check that CBC or that mammogram I ordered today? That happens to everybody. Mm-hmm. And that doesn't happen in MDVIP because you have the time to think through it during the day. Mm-hmm. And so those are the sort of things that can help you take care of people. So for when you're thinking of the numbers, I can say it's really anywhere between 300 and 600 is probably a sweet spot depending on the physician.
I am in the range of, and it varies because people move. Some can't pay any further. Some obviously pass away. So my numbers go down, but we still accept patients. I'm under 500. I know that. And I'm quite satisfied with that. It's easy to manage. And I think one other benefit that we didn't mention is that if a family member, like a husband and a wife, join, their children up to age 26 come in without a fee. And that's important to know because that allows them to say, oh, the whole family can still stay with you and I don't have to pay for my 10-year-old, my 12-year-old or whatever. So that's a good benefit there too. Can the concierge practice or model allow for subspecialties to also form a concierge practice, such as pulmonary, neurology, etc.? What do you think?
Actually, so yes, and We do have many subspecialists in the network, but they're just doing primary care. So I know you're thinking, like, can an endocrinologist do an endocrinology MDVIP model?
Mm-hmm.
We're actually piloting that right now for endocrine and cardiology.
Okay.
Because there's still in those, like, cognitive subspecialties, there's still that wellness and prevention mode, right? The endocrinologists are still trying to do wellness and prevention in their diabetics. The cardiologists, that's what they're. Yes, there are some who just want to do procedures and people who have heart disease, but there are many cardiologists who really want to be preventive cardiologists.
The clinical cardiologist, yep.
Mm-hmm. Yes, and those are the kind that can do that. So we're trying more, do I think a general surgeon could do this?
No.
Not under a VIP, likely.
Yeah, because generally the general surgeon takes out the gallbladder and never sees the patient again. But how about pediatrics? Pediatrics seems to be a good field for you guys to develop a process, no?
Yeah, and I think we've looked into it like 3 times. Definitely, and we will be probably piloting it again sometime over the next year or so. The difference is, for children, most things are covered services, as you know.
Mm-hmm.
So you're not talking Medicare, but you're talking like commercial insurance and Medicaid, like what are the legalities from there.
Mm-hmm.
And because so many things are covered, it would be very hard for me to develop that executive style physical for a kid that's non-covered.
Okay.
If you opted out of all insurance and did like a direct primary care model where you took no insurance and you just paid the fee for the kid, then that would work. So the reason we haven't piloted yet is we're sort of stuck in that conundrum of, do we give up on insurance, which is different than the MDVIP model, and do it more direct primary care? But then parents want your insurance to be used. I mean, we pay for our insurance, right?
Correct.
So that I want my kid, I want to be able to use my insurance for things. So that's just what we have to get the model sort of together before we pilot that.
Okay. Well, our wellness physical is what the fee generally pays for because it is quite extensive, as you know. But I still accept insurance for other reasons they come in, for example, diabetic checks or pneumonia or things like that. And I bill the insurance also, which is a good way that things should work. Can a doctor establish his own concierge practice without an affiliation with anywhere?
I mean, they could. There's a bunch of them all around the country. The things that we bring to you are the marketing, right? That when your patients love you, right? You're at the point where you're at the good number and you're not looking to grow your practice. But there are people who do, and really, because people do move away and die, right? You're going to lose 5 to 8% a year, and most physicians, especially if you were 40 or 50, are going to want to replace those patients.
Correct.
You're not 50, right?
I'm kidding. I wish.
I'm kidding.
I wish.
I know, me neither. So that's why I'm kidding.
Well, today's my birthday. I'm 75 years old.
Is it really?
It is my birthday today. Yes, it is.
Happy birthday.
Thank you so much. I'm 75. Right. I say I'm 75, and thank God I'm still alive. But go ahead.
And there you go. It's a perfect year to say that. So, now I lost where I was going, Nick. We went off on our birthdays.
Well, we were talking about can an independent doctor just do it on his own?
Okay. So we do the marketing and help with that. We have that legal protection of making sure that you're not, if you bill patients for services and take insurance contracts, then that's not good unless you're doing non-covered services. If you're doing it on your own and you're just doing cash pay and you're doing sliding scale and other things, you could be looked at that you're giving an insurance product. And so then you could be, fined, or OIG or somebody can come after you.
Right.
And this has happened over years. We have lots of cases. Ever since 2001 or 2 of doctors who have been investigated, have been told to shut down their practices because they're not operating legally in the world today.
They did it the wrong way.
Okay. They did it the wrong way. And so, and when you're part of the national network, you have that reciprocity for your patients, that education, that Grail test that I brought you, and all those other wonderful things that you don't even have to think twice about. And then we continually bring new services for the Executive Style Physical, the annual wellness program, because if something becomes covered, then I have to have services on deck to add something new.
Sure. Because
we still need that fair market value of the physical equals the price of the membership.
Well, I'll tell you, when I'm going to take the example of the gallery test in Grail. We've known about this as MDVIP physicians for, like I said earlier, 2 to 3 years, if I'm not mistaken.
You are correct.
And I started using it early on, and other doctors have said to me, "What is this test that you're ordering, and why?" Well, when I turn them on to it, they go investigate it, and they all come back to me and say, "This is an amazing thing," and it is cutting edge. I tell them, "This is what we get through MDVIP. We got a lot of things that no other doctors are even utilizing at this point," and that really sets the stage for our programs. And I have to give you all the credit, and it's obviously been an honor and a privilege to have you on with us today. But we're going to sum it all up. Anything else you want to add that maybe we didn't talk about?
No, I think we hit on a lot of the things about, I just think concierge medicine is a much better way to practice, right? Because when you have the time, the tools, the technology, you really can make a difference in people's lives and, and make them live longer, happier, healthier lives. That's what, that's why we went into medicine, you and I, right?
That's
we wanted
correct.
to save the world and save people and save a life. And, when I don't get to personally save the life like you do, but when I get to publish that we have less heart attacks and strokes in MDVIP because of that, the extensive blood work and the testing, and amazing doctors like you who really know about inflammation on top of cholesterol and know how to, treat and look deeper the cause of inflammation and help coach people on diet and exercise. Primary care docs don't have the time to do any of those things.
Back in the let me think of the year here. Back in the 70s, I did my master's degree at the U of D, Delaware, in biochemistry. And my master professor was working with a cardiologist from up in the New England area, who had a theory that it was more than just cholesterol that was causing the problem. This was back in the 70s. So he had an idea that there was something that we maybe even be taking in orally. I had to isolate from whole milk one protein, xanthine oxidase. And we showed that in the intima of injured blood vessels, that xanthine oxidase was in a high level. So this was an oxidation. This was oxidation and inflammation that was causing the initial injuries. Now we've learned a lot more. Everything seems to be on inflammation, this, inflammation, that. But that's just an aside. I thank you so much. Do you have anything else you want to put forth to us?
No, I just said that's so cool that you were doing research in that early on,
Yep.
and that now, all I do is talk about inflammation, I feel like, because it's at the root of everything. Everything.
And I hope we get a good handle on it. We're using monoclonal antibodies to take care of some of those inflammatory agents that cause autoimmune diseases, which I think are just rising at tremendous amounts. Everybody I know anymore has some autoimmune phenomenon going on. I think that we got to zero in on that and find out why that's occurring. Oh, well, Andrea, this has been a pleasure to have you on. I'm so excited. It's been a good conversation. This goes out to some 23 countries that are picking us up. This goes out to many followers that we have, and I hope maybe we've converted more doctors to think in this line, because seeing 40 or 50 a day, 5 to 10 minutes each patient, is not doing the patient justice, in my opinion.
It is not. Mine either.
Thank you very much. We're going to close. This is Dr. Nick Biasotto. Thoroughly enjoyed this conversation with Andrea Klemes. I'm going to say goodbye for now. We have many more podcasts in the pipeline, and they will be coming shortly. Again, have a good day.
This has been Delaware Healthcare Reality, a podcast presentation of the Medical Society of Delaware. For more information about MSD, visit our website, medicalsocietyofdelaware.org. For questions or suggestions regarding our podcast, email us at healthcare.reality@medsocdel.org. Thanks to audionautics.com for our music. The executive producer of Delaware Healthcare Reality is Mark Thompson. Delaware Healthcare Reality is produced by Tom Mitten. For the Medical Society of Delaware, I'm Lori Ann Rhodes. Watch for our next podcast episode. Until then, be well. The Medical Society of Delaware, MSD, is providing this podcast for informational purposes only. It provides neither medical, legal, nor any other professional advice. The views, thoughts, and opinions expressed by the hosts or any guests are their own and do not reflect the views or policies of MSD. Unless specifically stated, reference to any specific product, service, or entity does not constitute an endorsement or recommendation by MSD. Reliance on the information provided in this podcast is exclusively at the risk of the listener. MSD expressly disclaims any and all liability or responsibility for any direct, indirect, incidental, or other damages arising out of any individual's use of, reference to, or reliance on this podcast or the information presented in this podcast.